The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone. This is Deanna Helsher. I am a director of the Michael and Susan Dell Center for Healthy Living, and I am regional dean for the UT Health School of Public Health in Austin. I'd like to welcome you to today's webinar. We're offering this webinar as part of our events for National Public Health Week 2020. So we're very happy to see you all here. And I'm really pleased today to present our speaker, who is Dr. Linda Lee. Dr. Lee is an alumnus of the School of Public Health, and she's actually adjunct faculty at our campus as well. So she has a extensive background in this area in environmental health, and the microphone over to her. So Dr. Lee.
Hi, good morning, everyone, or depending on where you're dialing in from, somewhere else, but good morning. Can you flip the slide, please, Kate? You know, we've got a couple learning objectives today, just so that we kind of level set here what we're going to talk about. We're going to talk about how the air gets contaminated. We're going to talk about hospital environments, but this really could be anywhere. It's where people gather and there's groups of people. We're going to talk some about the research, particularly in air, pathogenic particles and how they travel, and some myths associated with our protections like contact pathogens and droplet nuclei and respiratory pathogens. We're also going to talk about how those particles, as they move throughout, can become airborne, and then why those might be dangerous to healthcare workers. We're going to talk about negative and positive pressure relationships and kind of what that means as far as air controls. And also we're going to look at UVC. So in my mind, UVC is part of the technology that science forgot, because UVC has been around for years, and then it sort of fell out of favor, similar to the time where antibiotics came into play and we could manage disease with antibiotics. So a lot of UVC was shelved, and it's still used a lot today, but we're going to talk about some of the new emerging technologies around the use of UVC and why it plays such an important role. Next slide. So just a little bit about me. I've spent a career as an industrial hygienist, environmental health specialist, and really focused on the air. And whether I was at MD Anderson or Waste Management or any number of the companies I've been involved with, I've always been interested in the relationship of the science to the air and the surfaces, because we had some very specific ways that we manage these environments for workers and staff and for patients, quite frankly. And so my doctorate is in public health, and my focus is on occupational and environmental health. But my passion really is to try to provide the safest and healthiest environment for workers, patients, and of course, visitors to the space. So I'm really excited to be here today, and my contact information is at the end. So if you're interested in reaching out and learning a little bit about my research, I've spent at least the last 5 years researching this area pretty extensively and have several peer-reviewed papers. So next slide. So why do we gather? Well, you know, at the end of the day, we're living through this pandemic right now, which is significant, of course, for most of us. But the real issue comes down to the fact that every year in hospitals, in healthcare, and in the environment that is part of healthcare, there's over 700,000 infections, and there's 72,000 people who die. So 1 in every 31 hospital patients, according to CDC, is going to get an infection that was not what they came into the hospital for. So in this infection control, infection prevention space is where a lot of my practice is. And I'm really looking at this as an issue that's like a 727 or a 737 crashing every day in this country, and people dying from this. And how can we get a handle on reducing the exposure? Because that's really what it's about, is it's reducing the exposure to these patients, whether they're immunocompromised, immunosuppressed, or just by age or any other number of comorbidities. They're more susceptible to getting sick, that maybe a healthy worker or somebody like that is not getting sick. Next slide. There's a huge cost to healthcare associated with this. If you could think about Medicare and Medicaid, their reported numbers is between $35 and $45 billion spent annually on these types of infections. And the impact of direct and indirect costs of them is $2. So it's not a small number. And one surgical site infection, one ventilator-associated pneumonia, one CLABSI, which is a bloodstream infection, C. diff infections, cost not only in human toll, so people being sick and or potentially dying, but in resources. And we know that hospitals run really close to the edge without a pandemic, without something going on that we're dealing with every day on bed space and capacity. So this is really an important number when you look at the industry of healthcare, which is a huge part of our domestic product, our domestic gross product. So this is an important number, and not only in the death toll and the injuries that we've seen, but also in the cost and penalties. Next slide. So we're not just doing this because there's a pandemic, but in social distancing, and everybody who's on this call in public health knows that if we can reduce the amount of infections, if we can reduce the amount of people, we're not going to continually to stress our healthcare system. But we know that in disease transmission and in infection prevention, that it's kind of like the fire triangle. If we interrupt anything from happening, then we're not going to have a disease. So we look at the infectious pathogen. In this case, what we're looking at right now is the COVID-19 disease, or the SARS coronavirus 2. So that's our pathogen. We're looking at the source. So where is it coming from? Well, we know the Academy of Science, from a brilliant lecture from last week, have now said, maybe this is actually not just a droplet transmission. Maybe this is airborne. So the CDC has come out and said, we'd like everyone to wear masks so that you're protecting not necessarily yourself, but you're protecting you from all the other people. So there's got to be a source of the pathogen. It's coming from somewhere. It's got to have a portal. So if it's coming from a person, how is it getting out of the body? Are they bleeding? Are they coughing? Do they have open wounds in the case of a bloodborne pathogen or something else, or a respiratory pathogen? And there has to be enough of it. So, is it 1 microbe? Is it 5 microbes? Is it 2,000 microbes? We don't necessarily know these numbers, but it has to be enough of it. And then the host has to be susceptible. Why are some people sick with this current COVID-19? Some people are asymptomatic and some people are pre-symptomatic. And then my area of focus is always, how is it getting into the body? What's the route of entry? How is it exposing people? So if I can interrupt that pathway and say, there's no exposure because I've put PPE on you, or I've protected you, or I've taken away the route of transmission by cleaning up the space, washing down the surfaces, so there's not enough of the pathogen in the air or on a surface to make you sick. So the whole focus is in this area. And in infection prevention, and whether that's in a workplace and you're dealing with Amazon, or that's in a hospital, it's all about interrupting this. And we really focus on three types of pathways: contact pathogens, which are typical high-touch surfaces I touch a surface, I leave the pathogen, the next person comes along, they touches the surface. Elevator buttons, any number of things, bed rails. And we focus a lot, you know, when you clean your counters in your home, you're cleaning the counters so that if you were cutting fresh chicken or something and there were pathogens left behind, you clean those up. So we're talking about contact. And then respiratory pathogens, we see this with measles or tuberculosis or things that we typically think about traveling through the air. And then finally are the droplet nuclei, which is kind of a hybrid of the two. So you cough and the heavier particles fall quickly and the lighter particles stay suspended in air. In this particular virus with the SARS Corona 2, you're looking at potentially up to 3 hours in the air. And those pathogens can go anywhere. They fly down the currents, they're kind of free radicals. They go where the air takes them. For instance, might land on the elevator buttons, and then you have a contact transfer. But the others are going to travel through the air until they find a home. They're either going to land, somebody's going to inhale them, or they're just going to go away. We know there are a lot of things that affect this disease transmission, and there's a lot of really good studies out there by Stephanie Taylor, who is a physician who studies humidity and temperature and the effect on viruses. If you're interested in a lot of really good literature on keeping humid spaces between 40 and 60%. So can we go to the next slide, please? So why is the air important? Well, I've always studied the air a lot more because a lot of people have studied surfaces, and we'll talk more about that. But when you think about surfaces, to get a chemical, for instance, approved for use, to be able to declare it to be able to be used on microbiological agents, you have to go through a lot of testing. And you are covered by EPA under a regulation called FRIFRA, because microorganisms are considered pests under an EPA definition. And so to manage these pests, you get an EPA approval and you go through vigorous testing, and you can make a claim against the chemical. It can be a viricide or a fungicide or any number of things. But when you look at the back of your Clorox wipe, it's got an EPA registration, it's under FRIFRA. So lots of studies go into surfaces. And there's a lot of studies out there on air pollution and things like that. And we went through a cycle where everybody was studying mold. But this sort of holistic air approach, we don't look at a lot. We don't look at a lot of air in the United States just in general in a space unless we have an outbreak. If we have a Legionella outbreak, we start sampling air, we start sampling water, we sample all kinds of things. But without an outbreak, we don't focus a lot on the air. And a lot of it's because what are you going to do about it? We have basically one way that we manage air in hospitals and buildings and schools and every environment, and that sort of is what it is. And so when we look at it, there's a whole lot of really interesting information coming out now. One that I liked that came out of CDC was on well baby visits. The cost of new influenza cases associated with well baby visits annually to families and to work and so forth is about $500 million of new cases just from well baby visits out of CDC. There's some information on Alzheimer's and funguses. We know that in nursing homes in particular, there's accredited by CDC 380,000 deaths a year occur because of things going on that are acquired within the healthcare, or excuse me, the nursing home or long-term care facility. We know that C. diff, and this was actually quite interesting, in a study in 2011, of the 150,000 people with C. diff, 82% of them reported that they went to a doctor or a dentist, not a hospital, before their case was diagnosed. So there's a lot of things going on in the environment, and these are all, of course, peer reviewed. And we find that when we look at these things, where are they coming from? And they're not all contact transmission, because if you think about contact transmission, just in general, you had to have contacted the surface or the person. But what if there's not this fine line? For those of you in healthcare, you know, we call it the red line. If you go into an OR, there's a red line, and nothing crosses the red line until they're properly gowned. But I don't think the pathogens necessarily get that message. And somebody could say, well, we have air processes to control that. But we know that when you open two different doors, a study out of Johns Hopkins says there's 80 door openings an hour from the sterile core to the main core. Can you imagine if you open those doors, you're basically bypassing your air controls. So there might be more to this air thing than we think. Next slide. So OSHA, CDC, everybody has this hierarchy of controls, and I left off substitution and for less dangerous products and things, which are really at the top. But one of the things that I like to think about in the environment and what we're dealing with literally today with this pandemic is the issue of engineered control. So if I have an engineered control, it works in the background, it operates without anybody doing anything, similar to an air handler is an engineering control. If you think about things that operate on all on their own, if you want it to be 78 degrees in your house, you set your thermostat and 78 degrees is delivered. But if it's like most homes, you realize that this room might be a little warmer or this room might be a little colder, and that's the air distribution system. Well, they work the exact same way in most schools, in most hospitals, in most areas. And one of the things that's interesting is some of the decisions by the National Academy of Science on SARS coronavirus 2 is that if it is airborne, how is it traveling through those systems and how is it being captured? So we're gonna talk some about that. Administrative controls on this hierarchy is surface cleaning or the UV tower or robots that they're commonly known, or hand washing, anything that people have to do. They have to rely on an employee being trained properly. They're not off that day, that they're following the procedures that you set up, that everything is working exactly as you have planned it to work. Administrative controls, albeit have a little more opportunity to be successful. We have to keep training people on it. We know that we are going to have a training program. It's like going on a diet. We get everybody on a diet, walking 10,000 steps, but we know that that is going to wane unless we can really get people ingrained in doing it every day and remind people every day. Well, the same thing happens. We tell people to wash their hands for 20 seconds. Does 20 seconds happen? I don't know. It depends how busy you are and how many times you can sing happy birthday in a row. So you look at this and there's opportunities for failure, and then of course PPE. And we all hear every day the debacle that's going on with PPE in the environment. People are trying to reuse things that are intended to be disposable. People are stretched to the max, taking them on, taking them off, doing all sorts of things. And I know people are doing the best they can, but even when we're not having a pandemic, we can all see examples. One of the things I do is survey hospitals for accreditation in the physical environment. And I can see signs up in places where people aren't doing what we ask them to do. They're busy, they're just, they just get overwhelmed with so many things to do on a day-to-day basis. If you can take it out of their responsibility, let them focus on what they need to do and create an engineering control. And so I spent a lot of the last 10 years working on how to develop these engineering controls to help healthcare workers, help people to have safer spaces without them having to do a lot of extra work in an already overburdened organization. Next slide. So I'm kind of setting the stage here for what we currently do in healthcare. You know, we wash our hands, we clean surfaces all day long. We terminally clean, so when people leave the room, the OR is empty. At the end of the day in a classroom, they clean the rooms, they empty the trash, they mop the floors. These things go on every day in everyone's homes and everybody's work environments, and all these are part of administrative controls to keep the space clean. Next question, or sorry, next slide. So technology is coming in to try to improve this. So the first picture you see is a computer cart. These computer carts are wheeled around patient to patient. So you can imagine this is a foam mic that goes room to room to room to room to room. If you've been in a hospital, you'll see they'll roll in a blood pressure monitoring equipment, or maybe there's a computer in the room that everybody's touching on. So we focus on all of these things, but these things also can add fomites to the environment, fomites in ways that things can be transferred from inanimate objects to people. So technology is coming in to try to help, but how is this technology competing or adding to an already overburdened, overworked organization? Next slide. So I want to talk a little bit about UV, because I like to think of UV as the technology that science forgot. So if you can think about the 30s, 40s, 50s, when people had tuberculosis, we put them out in the sun, we exposed them to UV light. UV is used in ORs all the time. You know, a lot of ORs will have after hours lighting where they turn this on and they bathe the OR in a UV light that glows blue and basically decontaminates surfaces. You can see the robot towers, they get rolled in, and you close off the room and you shut everything down and you zap the room for 15, 30 minutes, an hour, whatever it takes, and then you open the room back up. Biological safety cabinets. Everybody who's done any kind of science knows that in a biological safety cabinet, you have UV lights, and the UV, the sash is pulled down, the UV light comes on, it decontaminates. Air handlers, and this is probably what you have either in the building you're in, you may have it in your home, I have them in my home, and what it does is it really keeps the air handling system clean. So what it does is it treats the filters, it treats the drip pans. We had these when I was at MD Anderson, they're all over. And what it does is it keeps the system cleaner, reduces the amount of preventative maintenances on the system, and really keeps it clean. The picture next to it is your home air handler. So if you have these in your home, that's where they put it, by your coils. And then water treatment. But what all these things have in common is that there are no people involved when these UV lights are on. So the limiting factor to UV has always been that, you know, quite frankly, UV can be hazardous to people. So how can you design or think about researching not only the environment, but if these technologies are working, how could they be used in other applications? And so we think about chemicals. So we think about treating chemicals. And every chemical, as I mentioned, it has an EPA registration as a pesticide. So you're using pesticides under EPA's definition to reduce microbiology in an area. So if you can think about this, you've got this loading. The way pesticides work is you leave a residual, it continually treats things. But people also pick up these chemicals and on their persons, on their hands. And there are studies that show that the use of these chemicals for cleaning have created, at least in a couple of studies, higher incidence of COPD in nurses who are exposed to them. But do we want to give up the level of cleaning for being able to be sure that everything is safe for people to handle? Well, we've seen that our traditional thoughts of cleaning have still resulted in these levels of infections in hospitals and certainly deaths. So one of the things I've been focusing my practice on is trying to find ways that we can utilize UVC, which is kind of on and off. It's like a light switch. You turn it on, it treats. You turn it off, it goes away. There's no residual treatment. And there are limitations. You still have to clean surfaces. Nobody's arguing that. You still have to do all these things. But whether you're looking at scopes that are going to be invasive, whether you're looking at surfaces, how can you add this level of protection, but also not expose workers? So that's kind of what we're going to look at, is some of the, quite frankly, some of the research that I've been doing. Next. So for those of you who aren't familiar with the way it works, is that it works differently than chemicals. Chemicals, kill things, they wipe them away because you're wiping and removing, and that's how they work. The way UVC works is that it takes bacteria and fungus and viruses, and by exposing it to germicidal irradiation, it basically renders the bacteria, virus, or fungus unable to reproduce. So you still theoretically have a particle, but it can't reproduce. So it's now non-vegetative. It can't make you sick. So you can still have a particle, or you still could be sensitized to something, but it's not going to reproduce the way it would if it were not neutralized by removing DNA and RNA. Next slide. So we've seen that it's been proven effective. There are tons of studies on SARS coronavirus 1 that show that UVC is very effective. It's been studied on gram negatives, gram positives. It's got all kinds of studies on funguses. And in many cases, you can remove up to 99.99% of surface and air contaminations. So if you can think about it in terms of treating it. Now, the limitation on the air handlers is that you've got an air handler. We talked about this being 6 foot or six stories up or 15 stories up, blowing air through an entire manifolded system. You're delivering clean air because you're keeping your system clean. But what we've seen in studies at MD Anderson and others is that the pathogens are actually brought into the room. So these people depict that this healthcare worker went from room to room to room to room. So this is pre-coronavirus or COVID-19, because you see no protections in this room. And so the patient is shedding, the person is shedding, and all of these things are going into the room. So can we see the next slide? So I like to think of the air as the invisible threat, because when you think about it, people come into the room and they carry their own microbiome, they carry their own biological footprint. And if you're in this room for more than 5 minutes, and I were a really good CSI person, I could probably find that you had been in this room just by you talking, just by you interacting with the environment. So at an APEC meeting, somebody said, wouldn't it be cool if we could see the environment? So we took Pigpen here and we said, wow, look at this. We can actually see the environment, because with every step we take, there's a published study that says you're disturbing 100,000 particles in the air. Now, not every particle is viable. Nobody's suggesting that. But if you could imagine seeing every step you took, like our friend Pigpen here, and seeing the air, you'd go, oh, I better walk softly here. NIOSH has some really good studies on toilet flushing and healthcare worker, and these flush valves, we've all seen the water spray up. Well, you can imagine if that sprays all over the front of you. And we did some really cool studies in one of the hospitals I was in, where we put germ glow in there, flushed those, and we could show both healthcare workers and environmental services all that would be left on the front of their clothing. And then, of course, they would just go to the next room and take care of somebody, whether you're emptying a bedpan or whatever you were doing. We've seen 1,000 times the proverbial droplet, nuclei, cough, and sneeze. And so we know that during cold and flu season, this stuff is going everywhere. And so some of the things that we're doing today are things we should be doing every day during cold and flu season, particularly, but certainly now. We know that the government has just issued a wear mask, I guess, voluntary request, because not because we're protecting ourselves, but if we're asymptomatic or pre-symptomatic, we're protecting others. The interesting thing here is that if you're from Asia, and particularly Hong Kong, there are actually requirements in Hong Kong during cold and flu season to wear a mask all the time. And there have been studies out of there that showed that they actually reduce their levels of infection because everyone is wearing a mask. So it's not that we're protecting people from us. That's the point here. But in our country, we normally put the sick person in a mask. So if you're in healthcare, you know, one of your protocols, if you have a suspect TB patient, is to put them in a mask because you're containing their exhalations, you're containing what they have. But in a lot of countries, they wear this during the entire cold and flu season because they assume this works for them. So I think about, we use a lot of our senses when we feel threatened. So I was in the Middle East, I work a lot in the Middle East, and I was working for the Sultan of Oman, and we were in this hotel, and the fire alarm went off, like often goes on in hotels, and everybody literally went to their door and looked to the left and looked to the right, and they were looking to see smoke because obviously there was no fire in their room. They didn't smell anything, so they looked to see. And what did people do? But they go back in their room, they shut the door, and they assume it's a false alarm. And we respond that way to things we can't see or things we can't smell. Next slide. So these studies I put together are really kind of cool because if you've ever worked in healthcare or been associated with people in healthcare, they're always telling you to check to see if you're a healthcare worker or wash their hands. And you want your healthcare worker to wash their hands. We put sanitizer, you know, in the room. We put it on the way out of the room. We have hand sanitizer everywhere. But these studies were actually quite interesting because it studied the likelihood that a patient would get an infection if the prior room occupant had that infection. And so if you think about hospitals, and the rooms are terminally clean, terminally clean, terminally clean, clean between patients, clean, 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 cleaned. And if you have one of these contact pathogens, they're even cleaned more. Why are people getting sick? So they studied this room and they said, for instance, with C. diff, Shaughnessy's paper says you're more likely, 2.5 times more likely to get a C. diff infection if you were in the prior room person had that infection. So if we're treating all these surfaces and we're cleaning everything and sometimes super cleaning everything, how is this happening? And so looking at this led me to think more and more about the air as a pathway, where what we normally consider to be contact pathogens maybe are being carried on our own clothing, or maybe being brought in by family, or maybe on inanimate objects like flowers or boxes or whatever. So next slide. And so in some of the studies that I've done, and we're going to look at those in a minute, we can see contamination in the air up to 8 times higher than on the surfaces. And that makes sense because when you think about it, making a bed, for instance, you can have particles go all over the room making the bed. In a study that we did at MD Anderson, it showed that the highest particle activity in the room, and therefore viable exposures, was right after they cleaned the room. And so surfaces were always cleaner, or almost always cleaner, in rooms where we tested. Again, because in many cases, the surfaces are cleaned throughout the day. The nurse will wipe down a surface, or environmental services, housekeeping will come in and clean the room. And so this goes on continuously throughout the day. Your conference room is cleaned at the end of the day by a housekeeping service, your offices, the classrooms. But what do we actually do to clean the air? We rely on the one thing we have, which is the air handler. The air handler is our only way that we deal with the air. Now, if you're in a house, you may open your windows, but that's the way we deal with air. We do a lot of things. So the redundancy on surfaces is manyfold. In some cases, we have an N+1 redundancy. We can have an N+4 redundancy, depending on what the patient has. We also know that in the case of C. diff, in the studies that were done, 96% of the samples on non-high touch surfaces actually had C. diff on them. So if the transference for C. diff is surfaces, why is it in the air? So as researchers were asking, well, what's going on and what role do all of these play? Because remember, our controls are around contact. And so what we want to do is we want to see if there's a new paradigm to look at. So I think of the room kind of like a snow globe. If I walk into the room and I shake it up, shaking, everything coming and going, because in the study on C. diff, the highest activity for C. diff in the room was between about 9 in the morning till about 2 in the afternoon. And why is that? Because that's when the most activity was going on. So if we think about this room as being a snow globe, what goes up must come down. And so eventually, when the air stops moving, people leave the room, things start to settle out on surfaces. And then the air kicks on, and this whole cycle continues. Survivals, so pathogen survival, you can see here are typical pathogens of interest or clinically relevant pathogens and their lengths of stay on surfaces. Klebsiella can be 900 days. And so all of these studies have shown this stuff to last a long time. Even if you're looking at the current coronavirus, if you're looking at SARS or rhinoviruses or some typical respiratory viruses, they can last for days too. Next slide. So this is the episodic cleaning that goes on in homes, in businesses, and particularly in hospitals. So the patient is admitted to a perfectly terminally cleaned room. As soon as they open that door, pathogens start going in. The person gets wheeled in. Stretchers are moved from the OR to here. They come in a wheelchair, which is out on the street, comes into the room. They unpack their belongings or they get moved onto the bed. This biological loading goes up. We know that the average length of stay, 2 to 4 days. This goes up, but then they come in, the patient gets discharged, terminally cleaned again. We can imagine if you're a long-term stay patient and you're going to be there for 28 days, similar to what we're seeing right now, there's not that opportunity to continually clean these spaces. SHEA has a requirement that says we'd like the room terminally cleaned every 48 hours. A lot of hospitals can't do that because they can't get the people out of the room. They're critically sick, and moving them just isn't going to allow them to be able to terminally clean a room. So this biological loading occurs. So I'm looking at interventions that can reduce this biological loading, not eliminate it because it goes on all day, every day. It's like a bucket. So the hose fills up the bucket and eventually overflows. Well, can you imagine if you could put a spigot in the bucket, open the spigot and continually lower the microbiology in the room? And those are the technologies that I've been studying to see if it has any effect, not only on patient outcomes, but certainly on environmental outcomes. Next slide. So we look at surface risks, and surfaces have been studied and studied and studied. Interestingly enough, there's a study that I worked on that's just now coming out out of Stanford, and they inoculated 2 keyboards in an ICU with a mosaic virus created by the Cleveland VA. So we inoculated 2 keyboards with this mosaic virus, and within 48 hours, even with their cleaning practices, they contaminated 30% of the keyboards with that mosaic virus. And so interestingly enough, we know that these things transfer throughout the facility on fomites. There was an AJAX study done in a hospital. 1.4 interactions occur every hour with a med cart or a cart traveling from room to room to room. So when you think about this, we have this opportunity for transmission just by stuff that's traveling throughout the facility. So then you add the air on top of that. So you've got the surface potential contamination added with the air contamination. And we know that in many of these studies, this equipment is adding to this. Next slide. This was an interesting study. I just finished before, well, I just started before the COVID-19, is that I studied 10 different hospital sites, and I studied basically 2,000 keyboards or surfaces. So the wows, the cows, the keyboard arms, and of those, 70% of them had clinically relevant bacteria on them. And this is with their cleaning process. And their cleaning process was to clean the keyboards once a day. And so looking at this, you can see some of these, 38% of these items were too numerous to count with gram-negative or enterotoxin. I like to call this the fecal veneer of the surfaces. And so when you look at these are all pathogens of interest to the medical staff and to the staff to try to reduce the amount of stuff on these objects. So we're studying these, and this is the first step of the study, and this is brand new information. Next slide. So the other product that I've been thinking about and studying is that if we're so successful in the main air handlers, what happens if we could bring all of that technology to the room where the pathogens are actually being generated? And so we're looking at these to say, would there be an opportunity? So I often work in ICUs, and I work in a lot of ICUs, and they'll say room 13 and 14 are the worst. Our highest infection rates are there, and that was in one of the studies you'll see in Kentucky. I did a study at a VA in Pennsylvania, and they have 4 rooms they use. They call them the Wounded Warrior rooms. And those 4 rooms have the highest infection rates on this entire floor. And so why is that? And so studying the environment becomes really important. But what if we could bring all of our knowledge, remember, that's the only control we have of the air, to where the pathogens are being generated, similar to what we're doing with surfaces. We do lots of different things for there, but we don't do it in one room and hope it affects everything else. We don't do one keyboard and hope there's sort of this herd immunity effect that all the keyboards will be affected. No, we do it to every keyboard. So this is one of the things we're studying, is what if we did it at the source where it's generated. Next slide. So where do we look? Well, these are our areas of the hospital that usually have the highest either exposure because they have high-risk patients, NICUs, PICUs, oncology units, hematology units, etc. Suites where you're generating procedures, or you have decontamination rooms, or you have soil utility rooms, toilet rooms, and then, of course, high-density areas like EDs, nurses' stations, areas where you've got lots of people. Next. We do a sampling process where we're sampling for the air. So this is a typical air sampler. We're pulling 1,000 liters of air or cubic meter of air every 5.5 minutes. We sample for funguses and bacteria. And we use Rodak, and we use for surface sampling, as well as we do swabs. Then we sample the air, we sample the environment, and our ultimate goal is to look at the surfaces and the environment and see, A, are they matching, and B, what are the differences, and then looking at interventions. Next slide. This is a typical airflow. This is out of a facility in Nashville, Tennessee. So the ORs are positive, to a negative corridor, to a biohazard room that's even more negative. So There's 25 positive air exchanges out of the OR to probably 6 air exchanges in the corridor, which it makes it negative to the OR. And then the biohazard room is about 15 at a minimum under X-ray exchanges. So this is sort of your typical airflow. But interestingly enough, in this study, guess where the most infected area was in the hospital? And this is all behind the red line. So you got the pre-op on one side, and you got the PACU on the other. The doctor's lounge and the staff lounge by far was the most infected, like 400 CFUs per cubic meter of air and 400 CFUs per square meter of surface space. So it was really, or square centimeter. So it was really telling to say we have all these controls. So the OR was pretty clean, but the people walked right out of the lounge into the OR. So we looked at this whole OR setup. Next slide. This was a study we did in an ICU. Depending on what the hospital infection prevention and ID docs are most interested in, that's kind of what we studied. So we looked at infection rates, and we saw an overall infection rate reduction with an intervention for the air. And this was the guys who had the 2 units that were the most contaminated. So we saw a 60% reduction in these contaminants in particular, or these infections in particular, that the hospital said were most challenging for them. And the reason that we reported this is this was their experience. We're not saying this is what everybody's going to see, because it's not, but this was their experience. And interestingly enough, they also said some interesting things from their HR on illnesses. They actually had the lowest absentee rate on this unit during the time of the study that we conducted. So it was kind of an interesting study for them. Next slide. This was done by a pulmonologist and I in Tennessee, and we looked at this vent unit. Now this is a nursing home. It has chronic vent patients, compared one 30-bed unit to another 30-bed, I think that was the number unit. And the patients with the intervention for the air to reduce the amount of bacteria and so forth in the air actually saw a 28% reduction in overall infections to those chronic vent patients. These are patients who are probably never going to leave the facility. COPD, obesity, anesthesia accidents, strokes, so on and so forth. And so they were looking for ways that they could better protect these particular patients who are quite fragile. Next slide. And these are all peer reviewed, by the way. This was a Las Vegas psych holding area in an ED. Again, they did this more for their staff, because their staff was sequestered in these areas for long periods of time with patients who are there for a 48-hour hold, and they either get then admitted to the hospital for their issues, or they get sent back out to the street. A lot of these people are addicts or homeless or have a whole host of problems. They were pleased with the outcome, with a reduction of surface bacteria. So again, this is surface, these are settled surfaces. It's not high touch surfaces. Next slide. Same thing, we studied the OR break rooms. The OR break rooms were horrible. And again, because the OR break room, it only gets cleaned once a day. This was busy OR, I think there were 24 of them. It was active nonstop. We saw the same thing in their ICU. They saw a significant drop in their ICUs from air and surface bacteria contamination. Next slide. We studied a children's hospital in Texas, same sort of thing. They were having some problems with fungus. So when we studied this unit, we studied this room, and interestingly enough, their hospital has fan coil units. So each room is its own little environment, and the hospital and the hallways actually represented feeding from the main air handlers. So we had similar reduction in fungus in this room and bacteria. So we were able to really look closely at this environment. Next. We studied pharmacies. Pharmacies have to be compliant with USP 797, which requires a certain level of contamination. If you remember, in 2014, there were about 156 deaths across the country from compounding pharmacy. USP put in some regulations the hospitals comply with through their licensing and pharmacy board. This hospital in particular was having difficulty with their quarterly sampling, which means they had to shut down every time that they sampled. We studied the environment at length. We studied the air, surfaces, etc. We were able to bring them into 100% compliance by treating the areas outside of the compounding, because the way the air was exchanging between the pharmacy and the compounding area was what was contaminating. Even though it was 100% positive pressure, we would create air vortexes between the ante rooms into the room, which were leading to contamination. So they were able to come into compliance with their hospital policy on this. Next study. So all of these are published within the last 5 years. And the point of the whole discussion is really that there's not a lot of published information out there that you can say, well, why should I be treating the air? Why should I be sampling the air? But we're always trying to get better, and we keep adding things to this multimodal process that we have for treating air and treating surfaces. And so there's no one silver bullet. Not one thing is going to protect us. But having these many facets that's looking at interrupting these pathways, similar to what we would do for disease prevention, we believe is the best way for us to study these environments, and as public health practitioners, understand how we can solve problems and prevent illness and infection. Next slide. So I'm going to wrap it up with that, because there may be a question or two out there that I can answer, and I'm happy to do that. There's my contact information if you'd like to contact me, but I'll turn it back over to the moderator.
Thanks, Dr. Lee. Really appreciate you going through that. So you have several questions. So the first one is, I've been hearing about how long the pathogen, and I'm assuming this is the coronavirus, lives on different surfaces, but how should this be tempered with a consideration of the virus's half-life? How does the virus survive on surfaces, and how should we be thinking about the risk factor from surfaces?
Yeah, I think that's a great question, because obviously right now we can definitely talk in the SARS coronavirus 2. So that's the pathogen of interest. And then of course, the COVID-19 is the illness. So we're going to talk about the pathogen, and there's all kinds of information out there. But the latest study shows that it's at least in the air for 3 hours. They're collecting enough of it back after 3 hours. And again, it degrades and continues to degrade. We've seen it on cardboard in the same study for up to 24 hours, and up to plastic and metals for 2 to 3 days. Now remember, the conditions they're measuring in these are typically ideal. They're basically in test chambers, and so they know the amount they start with, they know the amount they're ending with, and that's how they're testing. But this is the time frames we're working within right now. If you think about your Amazon box, a lot of things have to come together before that Amazon box that's sitting at your doorstep is going to potentially be a pathway or a fomite of transmission. And mostly because there's a lot of environmental things going on that truck. It's hot, it's cold, it's humid, it's not. You know, the last person who handled it wasn't infected, so therefore they didn't leave anything on that box. So now it's been on the box on the truck 24 hours. So it's a great question, and we're learning more and more about this virus every day.
Great. What impact does UVC have on human DNA versus virus bacteria?
Well, that's the thing I was talking about being on and being off. One of the things you don't want to be exposed to is UV germicidal irradiation. We know that there can be damage to the skin. We know there can be damage to the eyes, as reported by the researchers who have studied this. So in all the technologies I'm researching, I'm looking at high intensity UV that is shielded, because there are technologies that use unshielded high intensity UV, and they have to block off the room, they have to leave it. You may have seen like robot towers or things like that, where they do a good job and they do obliterate everything that it contacts. But the inverse square law of physics says that it's a distance and a power that look at the level of treatment. So the closer the light is to the microbe, the more it treats. So you don't want to be exposed to this. So in my study, I'm looking for non-invasive exposures. So things that are contained within shielded operations that can work 24/7 in occupied spaces. So yeah, there is some disruption. So for the same reason you don't want to expose your eyes and your skin, the DNA from microbes gets interrupted by that. We certainly don't respond the same way an individual microbe would, but over time you probably would. So that's why there can be issues associated with UVC. But we don't want to be exposed to UVC germicidal irradiation. 254 wavelength is what I'm usually studying.
Great. So question, thoughts on what's best to get for a mobile dental van in terms of cleaning the air?
Well, the units that we studied to go in the ceiling are available for any occupied space. There's I think several vendors that do that. There's also vendors who have units that roll in, but in most cases, I don't like the roll-in unit, not because it doesn't work or it might not be effective or whatever, but because it's in the way. So if you're already in a cramped dental office, you don't want to be tripping over it. Also, the unit that I showed you in the air really, it doesn't generate its own. It has a fan, so it's actively removing particles, microbiology, but it's very quiet and it's moving it gently. So it's really working with the things that are transmitting or transferring the pathogens room to room to room. So any of the things that we talked about have been commercialized and are certainly available for a doctor's office or a dentist's office or anywhere. And there have been, it's not really a plume management because that's where your suction lines work. That's the whole idea of having a suction line, is you're managing plumes. It's really for all the residual that occurs once you stop the suction or once you stop doing whatever you're doing, that then have a backflow or a backwash into the environment, similar to what an OR has when you block the laminar flow. So.
Good. Another question, is it possible to prevent coronavirus transmission between people who live in the same household?
Well, certainly anything's possible. I think all the studies out of China said that the highest transmission rates were between people who lived in households where there were other people. But if the CDC guidelines is probably the best you could follow at this point, is that most opportunity would be to isolate that person, keep them in their own room, if possible, with their own bathroom, and then, deliver their food, but, practicing great hand hygiene, great hygiene practices that would eliminate the exposure, quite frankly, to other members of the household. So that's probably the best way if you're living with somebody who is either positive, presumptive positive, or symptomatic for anything at this time, is to isolate them as best as possible. Bag their laundry, be sure you're washing your hands all the time, and you're really focused on really good hand hygiene and surface decontamination.
Great. Well, we're at time now, so I'd like to thank you again for giving this webinar. We really appreciate this information. We do have a few more questions, including a request for some of the peer-reviewed sources on a few of your slides. So we can perhaps follow up and get that information and send that out to people who are on the webinar. Just one more piece of information. We do have a recording of this webinar, and we will be sending the link out to everyone who registered. So you will be able to access this recording later and share it with other people. So once again, I'd like to thank Dr. Lee and remind you all that this is part of our National Public Health Week activities. So thanks again, and we hope to see you on another one of our webinars in the future. Take care.